Hi, everyone, and welcome to the Next Generation Seminar Series, the MFP. Next Generation Seminar Series is a networking event by Field Institute for Early Career Scholars, junior modelers, and epidemiologists working or interested in mathematical modeling of infectious diseases and other threats to public health. This weekly seminar provides an exclusive online space for presentation by guest speakers, journal club, and opportunities to present new work in a supportive environment. First of all, we wish to acknowledge this land on which the Fields Institute operates for thousands of years. It has been the traditional land for Huron-Wendat, the Seneca, the Mississaugas of the Credit. Today, the meeting place is still the home to many indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Nous souhaitons reconnaître cette terre sur laquelle l'Institut Fields opère, sur la terre traditionnelle des Huron-Wendat, des Sénèques, des Mississaugas, depuis des milliers d'années. Aujourd'hui, ce lieu de rencontre abrite encore de nombreux peuples autochtones de tout Turtle Island, et nous sommes reconnaissants d'avoir l'opportunité de travailler sur cette terre. So for today's seminar, we have our guests, Fangli, Anjali, Marie-Anne from Durham Region Health Department, also Eleodor and Peter from Ontario Tech University, and they will present an app. Their app is based on multi-stratified susceptible exposed infectious removed SIER compartments or model that can be used by local public health units to perform epidemiological modeling of infectious diseases. It can accommodate multiple stratifications, virus variants, and levels of vaccination, as well as public health measures such as physical distancing, contact tracing, followed by quarantine, and testing, followed by isolation. Dear guests, the floor is yours.
Okay, thank you very much. Hello, everyone. My name is Pietrusiak. I'm just going to share the presentation. Okay. Hopefully everyone can hear me and everyone can see the slide. So the way that we're going to run the session today is that just have a brief presentation to give an overview of the project. We're going to be focusing more on knowledge translation and the communicating of this model, and also our general COVID stats to public health leaders and others. So that's kind of how we've been asked to present the information. This is a very kind of informal discussion. So each of the 5 members of the team will have an opportunity just to introduce themselves. And we're welcoming your questions and comments so that we can have a discussion and really delve into what you're more interested in. So the presenters for this session, there's myself. I'm a manager of health analytics and research at the Durham Region Health Department, and I have a team of 8 epidemiologists, 2 of whom are Fangli and Anjali Pandya. And then we have partnered since the summer of 2020 with Dr. Eleodor Nichita, who we will often call Doran, if you hear that us refer to him in that way, and Peter Schwanke, who are from Ontario Tech University, both in the Faculty of Energy Systems and Nuclear Science. And they can share with you how that faculty relates to infectious diseases, which I'm sure some of you will find interesting. So an outline, very briefly, we're going to talk a little bit about our data tracker, which is our main way of communicating COVID-19 statistics to the community. And the community is very large in terms of public health leaders, but also the general public, media, officials, ourselves, that sort of thing. And then also we'll talk a little bit about the model and the ID SIM application that we've developed and how we share those results with our public health leaders. So first off, for the data tracker, this is really an interactive dashboard. We use Power BI to provide COVID-19 stats for Durham region residents. And the idea is to be up to date, readily available, transparent, accurate, and easy to understand. So this really informs a whole pile of different audiences, including our public health staff, local politicians, community partners, such as hospitals, long-term care facilities, that sort of thing, media, and general public. It's used to understand COVID-19 patterns and trends and to support local decision-making. The data tracker ultimately, we hope, encourages adherence to public health measures in Durham region, including vaccination, and it's continuously enhanced with additional information as the pandemic evolved. So it started as one page and then it developed to multiple pages over the 2 years. And it's also used to showcase some of the other information products that we have, such as our summary reports and our flu tracker. So this is what's sort of a screenshot of what's included in the data tracker. We have case summary information, which shows cases, hospitalizations, and deaths. You can look at it by age and gender. Over time, there's a time slicer, so you can look at very specific time periods. We have institutional outbreaks. We have our wastewater information as well, where we monitor 7 sites for SARS-CoV-2. Vaccination tracker as well that looks at vaccinations, plus a weekly snapshot that provides sort of a summary information, including lab testing, percent positivity, that sort of thing. So a lot of information on the tracker. The ID SIM application started, as I mentioned, back in summer 2020. At the time, there were national and provincial modeling that was going on, and public health units were being asked to also provide some idea of projections, what might be happening with caseloads, that sort of thing. We did a lot of the public health units basically took these provincial models. There were some options to plug in numbers for the health unit, but we found that it really kind of overestimated a lot of the numbers. Plus, we had no flexibility. So we were approached by Ontario Tech University to submit a grant, an NSERC grant, and to see whether we could, between us, develop some kind of modeling application. And that's what we did. We were granted the money, and it was a very nice partnership that developed, that we all learned from each other. So ID SIM is a SEER model. It started off pretty simple, but as COVID grew more complex, Fangli, Anjali, and I kept basically adding more things that we wanted to see in the model. Can we add, for example, different variants? Can we add vaccination? So all of these things kept getting added in and kept making the model a bit more complex. So we have a bunch of different stratifiers or ways to stratify, such as household, a range of public health measures, multiple variants, vaccination, and waning immunity. So the question is, how do we communicate then these modeling results to our local public health leaders? We do disseminate the results on a regular basis, generally weekly, although the last couple of weeks, given the lower case numbers, I thought we'd take a little bit of a break. And we demonstrate how we can use the model results to raise questions and generate discussions. This is a flowchart of the model. I thought since this is a math group that you would be interested in seeing this. To me, it's totally overwhelming, but Peter and Doran can definitely, they're the brains behind all the math parts, so they can provide a lot more information about this. But the question is, how do we take those complex pieces of information and distill it down in a way that's useful for our senior leadership? Really, what we end up doing is we have a PowerPoint presentation that provides key information, key points, and that we update on a regular basis, and along with graphs that are very easy to understand at a glance. So our weekly updates has key messages, a short-term projection of case counts, hospitalizations, and deaths, and a longer-term projection, not that long-term, just usually about 30 days, I think. And how we demonstrate how the modeling information can be applied. Well, we have the short-term projections to keep up with the new information. We have longer-term projections when needed for planning. And we've, as a public health unit, we've gone through just a lot of ups and downs over the last couple of years. I'm sure everybody has, but working within public health and going up and down with the caseloads has been very challenging. So being able to have a sense of what might be happening in the future is very useful. So the projections we provide in our weekly update, we look at a couple different scenarios, multiple variants, different public health measure levels, and different vaccination levels. Actually, usually we keep it at one vaccination level for our weekly updates, but we have the capacity to change that. It's also used to predict peak case counts and workload for public health units, because that's, again, something that we're dealing with on a day-to-day basis. We can evaluate strategies to control the epidemic, and it's used to explore the importance of vaccination and other public health measures. So we're just going to kind of give you a couple examples of how we use the modeling application. And this has a nice little animation to this graph. So I'll just let you see that as I go to the next slide. So one thing we started looking at was multiple variants. So again, when we started with the application with developing IDSIM, we didn't have the problem with multiple variants. It started coming, and especially with something as dramatic as Omicron, it really changed our landscape. So when we were first dealing with Omicron, we knew it was more transmissible than Delta, but we didn't quite know how much more transmissible it was. So the model gave us the option to try, see what would happen if, say, Omicron was 2 times more transmissible than Delta versus 4 times. And then the other piece that was real big question mark at the beginning was whether vaccine effectiveness, how much that was going to be affected with Omicron. And again, we could model different scenarios for vaccine effectiveness. We could look at different levels of public health measures, and so this was important because, I mean, these were constantly changing. Not only in terms of what was being recommended, but what people were actually doing. So that we could look at over time. And then the model can basically evaluate things like vaccination rates. We can look at our case management and contact tracing, as well as other public health measures. And what we found in that looking at that is that on its own, vaccination wasn't sufficient. The case and contact management made actually a huge difference in terms of the case numbers and the growth. So the modeling basically provided decision makers with multiple scenarios to evaluate the best practices for moving forward. We could compare our results with other models, mostly the provincial models from the Ontario Science Table. We could compare it with models from PHAC. And we found that we were actually pretty consistent with what they were showing at a provincial level. That is for the most part what was going to be happening in Durham with a, just in terms of more specifics for Durham region, but in general, that's what we did find. And then we found that the model could help us with some of the questions, like what happens if we stop contact tracing and case management. And we did show that we needed the additional public health measures. Vaccination wasn't going to be enough. We also were able to look at things like waning immunity and what data are available for projections and how to improve that data quality. We could also look at things like what would happen if we stopped the contact tracing. And there was some good examples from Alberta from wave 4. And I already mentioned that vaccination was not enough to basically control a pandemic. And here's just an example of what happens with waning immunity after vaccination. So that gives you a little bit of a taste of some of the results that we had and how we use them, how we continue to share that information with the senior leadership. I suspect that suspect cases will again start to increase when the cold weather comes back, unfortunately. Hopefully we'll be in a better shape to deal with it. But we will again start our weekly projections when we start seeing some changes and hopefully be ahead of the curve. So that's where I'll leave it. I will now maybe let each of the different team members just say a few words, and then we'll open it up for questions. So I'm going to start with Doran because I think he can provide some perspective in terms of how we develop the model and his perspective from the university, and also coming from more of a mathematical background.
Right. Thank you, Marianne. Yeah, the way this sort of evolved was that in the late spring,
well, it looks like we lost Doran. I'm sure he'll be back in a second. Can you hear me okay?
For some reason, I got disconnected, but
okay.
I seem to have been reconnected automatically, which is all good.
Okay.
So I'm not sure what happened there. Okay, so as I was saying, in spring of 2020, this call for proposals came out of NSERC for to address needs specific to the evolving pandemic at the time. And one of the things that we realized was that, there were some models, and this was, now modeling was a very active area of work. But pretty much everybody had their own preferred software package, preferred method of approaching the epidemiological modeling. And these were generally teams made of several people, a good number of which had a background in mathematics or some other quantitative discipline. And over here, what we had were what we're doing is reactor physics research. So, and there's very few things that a determined physicist cannot simulate. So we figured, okay, maybe we can contribute to this by creating a tool that can be used by people that have good knowledge in epidemiology, but not necessarily a background and experience in mathematical modeling. So that's why we reached out to Marianne and the team at the Durham Region Health Department to ask them, well, do you think you could use something like this? And they said, yep, we could. So then, we got together, we put out a proposal, and NSERC was in agreement with us and funded this. So that's pretty much how this started. And again, the objective here was to do to come out with a software that was easy to use with very little training, and that did not require high performance computing. So you didn't have to have hundreds and hundreds of CPUs, something that would work on a desktop computer. And that had a model that was relatively easy to use and with a relatively simple input. So the compartmental model sort of came out as the winning approach to this type of modeling. Although even at that time, right, people were already beginning to look at agent-based models and so on and so forth. But that was not sort of what we were after. The other thing is that all these epidemiological parameters, they kept evolving, and they weren't always that well established. So, you can make a model that's very, very detailed, but if you don't have parameters to feed this model, then you can't really trust it that much. So I think I'm going to leave it there for now, and I'm just going to answer any questions that may come up later.
Okay, I'm going to let Fangli talk a little bit about her experience with the model, because she has been the epidemiologist who's been most basically the person to run it, and on a weekly basis. So Fangli, do you want to just say a few words?
Sure. So it's really nice to work with the team. I think I learned a lot in the past year. I remember we started the model, and it was Excel sheet. So Peter did the Excel sheet for us, and now involved into the ID. So I run the model very frequently. I find it's really, really easy to use. And although it can have lots of flexibility, but in terms of inputting parameters, it's pretty easy and straightforward. So, but give you a lot more flexibility. And as an AP, we like to work with numbers. So you get a nice output of the Excel sheet. You can do all the graphs, and you can play with the numbers. So, and I also, when I was working with this model, I also looked at other options like the PHAC one. You need to download the kind of software, but there are limited capacity of what parameter you can input for this one. I feel like especially for APs, you can do some it's an in-house application, and And also have the two genius, and they have advice, and they can add more capacity to the model, so enable us to do more things. And not just for the COVID, I think this model can also use to do simulation of other infectious diseases. I think it's applicable for other infectious diseases as well. So yeah, and yeah, that's one to see.
Yeah, that's a good point, Fangli. That was one of the things that we were thinking at the time as well, that we could adapt the model for, say, influenza or some other infectious disease. It doesn't have to be COVID. Anjali, did you want to say a few words?
Sure. So I've been one of the epidemiologists on the team, and my involvement was mostly with the data side of things. I've been heavily involved with the data quality checks and that side of COVID in terms of like the provincial system. So the data that we fed into the parameters had their own sort of limitations because a lot of the procedures and protocols had changed as the pandemic evolved. And so that definitely had an impact on the quality and availability of data. And just sort of discussing the impact that that would have on our modeling and the estimates that the model provided. So that's where most of my work has been, but it's been a great learning experience for sure.
Great, thank you. And then Peter, as a postdoc, I think you can relate to all of the people on this seminar. So do you want to say a few things?
Yeah, so it's been a wonderful opportunity to work on this. So my work then has been more again on the development of the tool itself, and so the preliminary work and providing results against which to verify the final model. And one of the things that Dor and myself found was very helpful was to sort of address the solution of these equations that we're solving, which essentially have a great similarity, whether it's the evolution of a pandemic or the decay of radioactive isotopes. The solution scheme is very familiar. And so then we both worked separately to solve the same problem. And so in some ways, there's a redundancy there, which then also helps to illuminate any issues, so that if our results don't match, then we had a way of determining which one of us was perhaps in error. And so I think in the end, it made for a more robust tool. And so again, yeah, it was a wonderful experience. And I think at the end of the day, yeah, we have a pretty good solid tool that can be used for this kind of modeling. So yeah.
Okay, so we are open to any questions, any points of discussion from the group. And I'm not sure, can I have one of the facilitators kind of facilitate, just because you know the players, it might be better for you to do that.
Okay, Sarah, do you have any questions?
Yeah, I just had a question about whether you've had a chance to look at the co-circulation of influenza with COVID for this next season.
No, we have not done that. What's interesting is we do have our flu tracker, and normally we would have shut down our flu surveillance for the season, but it's been an unusual season in terms of the flu cases are still appearing. They're still there, the numbers are still very low, and it's interesting going through COVID because so much work was done on the case ascertainment and the case and contact management. So you're actually getting those cases. The problem with influenza is that they won't test everybody. Once they detect it basically in the community, they will only do swabs for certain people, certain groups, even much more limited than what they're doing for COVID. So that presents a real issue in terms of you're just not getting the case numbers in the same way that you are for COVID. So I'm not sure how we're going to solve that kind of problem. Did you have some suggestions, some ideas?
I know we're looking at it as well as like what's the next season, because without the public health measures that have been in place, which has really suppressed the last COVID, the last flu season we'd anticipate. And then there appears to be some interesting things happening this winter in the Southern Hemisphere. So we would imagine that there's going to be, a similar co-circulation of a number of respiratory viruses, and not just COVID-19, which your model, if you're able to, work with that, actually could be really useful if you're using some of your previous observations from previous flu seasons, being able to run some of them together, but not like it's easy. Just might be a useful, you've set up this tool, so whether you can use that to try and help plan for the next season.
Yeah, for something like that, we may have to, it might require some additional programming in the tool, I think, to add in two different, to say add COVID and influenza together. So we'd have to give that some thought for sure. I see Gabrielle's hand. Hi, Gabrielle.
Hi, Marianne. Hi, Fangli. I'm going to just lower my hand for a sec. I have a couple of questions, and I think, so for the group, I used to work with Durham Region as an epidemiologist, and back, this was, I guess my daughter's 14, so it was 14 years ago, and modeling wasn't even on the radar, right? And I know that COVID has really brought modeling to the forefront. Everybody knows what a model is now and things like that. And so, I guess at the beginning of this, was it a really, so my first question is, was it a tough sell for you to approach senior leadership to say that, this is a really good thing to do, let's, try this out, let's, devote some time and resources to this? And then my second question kind of goes along with it, was the decision-making based on modeling results, was that a tough sell as well? Or, were decisions based on the modeling, or were there other factors that went into sort of leadership's decision-making, if you know what I mean?
Okay, those are great questions. Okay, so in terms of selling the project initially, well, what was interesting was that we were getting models that were coming from various areas. So David Fissman was modeling, Ashley Tuitt was modeling their kind of projects, and they had them at a provincial level, but you could plug in your local public health units numbers, and so a lot of the public health epidemiologists were playing around with these to try and figure out. This was early on, and actually that's how Anjali kind of got into the project, was that I kind of said, Anjali, can you just deal with this, try and play with these numbers and figure out what's going on? And there's lots of discussion in AFIO going on. So AFIO is the Association of Public Health Epidemiologists Ontario. If you're not part of that group and you're interested in epidemiology, you really should be. It's just a great group of people. So there was a lot of chatter back and forth about how we do that. So, and then some health units, I think, went much more into modeling based on that. So I know Hamilton, I think maybe York and Peel actually pay a company to do some modeling. So they have partnered, and this company does the modeling for them. Hamilton, I know, has used this extensively. We went a different route, I think, because basically Ontario Tech approached us and said, do you want to partner and see if we can get an NSERC grant? At our health unit, we're pretty, our leadership is very flexible in terms of that. They are always keen for us to partner with research organizations in whatever way seems appropriate. So we don't have a lot of there's a lot of freedom really to do that kind of work. I'm not sure that I expected us to get the money. So it was a little bit of a surprise when we did. And then it's like, okay, now we've got to do this. So that's kind of how it all came about. In terms of decisions made, I'm not sure that there are a lot of decisions specifically made from the modeling results, because there's so much information that is coming after us in terms of just our own local information. We have, obviously our cases, our deaths, our hospitalizations, our outbreaks, percent positivity. We have our wastewater data. Just that alone is a lot of information. Plus you add on everything that's coming from the province, and there's just a lot of, then you have all the international pieces. There's just so much information that any of the decisions I think are based on a whole pile of things. Plus, really, it's the province that dictates pretty much what we do. For the most part, the health units can maybe go off in slightly different directions if, say, their numbers are quite different, but pretty much the province dictates what we do in terms of vaccination, public health measures, case and contact management, all of the guidance documents that come that basically say, thou shalt do this. This is what your case definition is. This is, it's pretty strict, really. So there's some leeway, but not a lot. And I think we may basically look at things, our own data, and sometimes we breathe a sigh of relief, and sometimes we just kind of have a little bit of a panic, thinking, okay, this is, and even within Durham region, we may have certain hotspots or certain other pieces that we know that are slightly different than what's happening maybe in the rest of Durham region. So there's a lot going on.
Okay, thank you. There is a question by Jumi.
Thank you so much for the great presentation. So I'm just curious, actually. So thinking of co-circulation of COVID-19 and influenza, then emerging of infectious diseases like monkeypox. So I'm just wondering how expandable and reproducible is the hub to other infectious diseases or emerging infectious diseases?
Yeah, I'll start, and then I'll let the other team members jump in on this. So we haven't applied it for other infectious diseases, but the flexibility in the modeling is there so that you could change a number of the parameters. And I don't know if any of the team can, bring up the tool and just show maybe some of the dialog boxes that might give people a different idea for how you could do that. For something like monkeypox, which is transmitted so much differently in terms of very close contact, I'd have to really think about that in terms of how it could apply. I think you could. Is just some of the parameters. So there are certain assumptions that we are making as we're filling in the different numbers. So we assume, for example, there are people are having 10 contacts per day with other people, but that parameter can change, and depending upon your public health measures or just the group of people that you're looking at. So there is some flexibility, but it may not be enough flexibility for some diseases, I think. So does anyone else want to jump in there?
I think, so Dora, I guess if maybe you can bring the application, but I just want to add,
I'll try to see if I can get it from somewhere here, but yeah, I think that generally there's no reason why this wouldn't work for something like monkeypox. I'm more worried about things that, you know, you get an infection and then it's dormant in the organism, I mean in the body, and then it reappears after a year or two. That's the type of diseases that I would be more worried about. Something like monkeypox, I think it would actually work reasonably well. Again, the thing being though that if you have few numbers, right, just the statistical fluctuations will be bigger, right? What you get is average numbers from a compartmental model. But anyway, I'll let you, Fangli, and I'll see if I can get this.
Yeah, just so if you are to start the model, you need some like estimate number of cases in your community or the hospitalization, and then you can plug number like your latent period, infectious period, incubation period, and also the contact rate, and also your reproductive number. So you need to have some basic information about the disease. So hypothetically, you can model like, what if we have one monkey pox case in our community, and then if we have this transmission reproductive number and this incubation, so if we plug in the number, what will look like? So you can have some kind of hypothetical scenario to show what the case will infection will unfold over time. So I think a technique you can do that in other model. And also want to add, Gabriel asked the question about how we use the model. Like, I agree with Marianne. Like because there's so much information about the COVID. I think modeling is one of the many, and I think most of them you can use to inform or reassure what we know, or especially when you see the long-term projection, you see where the peak is. So you can have some kind of idea, but in terms of decision making, I'm not sure, but I guess more informing and also reassuring. Yeah. So I don't know, Dori, if you have your application.
Also, I have a couple of questions about how do you estimate the parameters to use it in the model? And also, you mentioned wastewater. Maybe the issue that Sarah talked about, maybe it can be used instead of testing people, to use waste management for this topic. Can you talk about a little bit about it, because you mentioned it and you talked a lot about compartmental modeling?
Right. So I'll start, and in terms of the parameters, there's two main ways we get that information. One is from our own data, that is sort of the nice thing about this model, is that we're plugging in very specific numbers for Durham region. The other information we really get from the literature in terms of things like incubation period, that type of thing. It comes from our general knowledge of the disease. In terms of wastewater, that's an interesting question, and I know that the science table, for example, looks at wastewater as part of their projections. We're not quite sure how they do that, and wastewater does have a number of. It gives you a very good idea of generally how much COVID is appearing within the population, but we can't get it down to specific. We haven't been able to use it, for example, to estimate number of cases. It's not that precise. There's a number of different parameters. For one thing, you have, we have 7 different sites that we're measuring wastewater in, that basically in southern Durham region. So we kind of have Pickering, Ajax, Whitby, Oshawa, kind of Curtis area, which is sort of east or West Clarington, and then we have Newcastle. So we're going into smaller communities. If you can have people coming in or moving out of a particular area, and they, for example, if they're commuting and working in downtown Toronto and they are there for most of the day, they are not using the washroom in Durham region. And so that wastewater is not going to be pick up their results. Conversely, you could have people coming in along the 401 corridor as they're traveling through, and you can be picking up wastewater results from there. The other thing is that how much virus people shed can vary greatly individually. So there's still a lot of question about how precise it is. So because some people can shed a lot of virus and others may not. There can be also, there's some suggestion that Omicron, there's a lot of virus shedding, but isn't necessarily corresponding with an increased number of cases. So that's why maybe some of our wastewater levels are quite high right now, and maybe our cases aren't as high. So it is a little tricky. People are, I think, trying to do it, but we haven't really gone down that route so much. So I'm just going to let Doran show a little bit about
Yeah, sure. I was going to say, as far as parameters, we don't really have a system to fit those parameters to data that we actually get through surveillance or just following the number of cases. This is a predictive tool. It's not a tool to sort of fit the parameters. So we have to use reliable parameters. The only thing that we can fit is the overall transmission rate, and even that needs to be done manually. We were thinking of adding, such a capability, maybe do a least squares or something, but that would have to come in the form of another application to NSERC, which we haven't done yet. So that's where we are with that. So anyway, I was going to, since Marianne was suggesting this, I can show you. You can probably see this, hopefully.
Yes.
Yeah, so it's relatively easy. It's just a simple, you just select commands here. You select the working folder, then you can set up the general simulation parameters. Once you have done that, you can load them. So for example, the number of stratifications, number of vaccination level, number of variants, number of contacts per day, something like this. Then you can go into a little bit more detail, set up the vaccination. For example, this only has one vaccination state. That's why you only see one, which says unvaccinated. For example, if I were to change the number of vaccination levels to 2, then I would go here, and the number of vaccinations now would have 2 levels, and I can give them names like unvaccinated and maybe one shot, and the people are transferred from one compartment to the other, respectively. In this case, from unvaccinated to vaccinated. You can do it either using persons per day. This is what you would use if you did vaccination. But for example, if you were also to account for vaccine immunity, vaccine waning then what you would do, for example, in a single shot scenario, for example, you would have 3 levels of vaccination, right? You would have unvaccinated, vaccinated, but then vaccinated, but with immunity waned. So then how you would do that is, let's say you would have here unvaccinated, then you would advance to vaccinated at a certain rate, say 100 persons per day. That's how many you would be vaccinating. So this would be vaccinated, but then you would be moving to the third, which would be waned immunity. Then you would have days before advancing. So let's say you would have 30 days here, right? This would mean that within 30 days, your immunity would be considered to wane, or it could be 60 days, or it could be, whatever the waning period turns out to be. So this would be waned immunity or something to that effect. So then, the stratifications can then be set up. Stratification 1, say, for example, this could be by age. And then, okay, so by age, let's say you would have below 50 and let's say over 50 and things like that. And then you would have the fraction of the population that belongs to that stratification, the vaccination fraction, and so on and so forth. Again, there's a bit of a balance here between making the model fairly complex and not making it so complex that it stops being useful, that it requires too much effort to. So yeah, that's pretty much how we input the data into the model. So I think I'm going to stop sharing this now and see if Fangli has anything to add to the type of parameters that we are able to use and the type of sort of manual fitting that we did.
Well, did you show the initial population, that screenshot? Okay.
Yes, I can. So let me try to do that.
Yeah, because that's another kind of the set of parameters you need to,
yes,
right? Because you need to have something to start the.
Yeah, hopefully the file that I just loaded allows me to do that, because I didn't know that we were going to do a demonstration, so I haven't really prepared a good sample file here, but let's see. So set up variants, set up public health measures, initial population fraction in each compartment. This is where you would, distribute your population in all by all compartments. So you see you have exposed, quarantined, infectious in community, asymptomatic, infectious isolated, asymptomatic, infectious quarantined, and so on. This can get pretty detailed depending on how detailed the breakdown is.
I guess the nice thing
but
is
you wanted, yeah, go ahead. Yeah. Is that what you wanted me to show, or did you want me to show?
That's
this is okay. Yeah, okay.
This is the initial. So you need to have something like an example with that, because the one of the lady asked the monkeypox. So you can start with one case in your community, but you have to start with something. But nice thing about this, you don't have to put numbers into all these boxes. You can just start with some number, and you and it will rebalance. So it's because based on what you input in your previous windows, if you there's a rebalance feature, and it will recalculate the actual fraction for you.
Yeah.
Since you mentioned the wane of vaccine, how did you describe it in mathematically or numerically into the model?
It's just another compartment as I was showing you. Let me bring that up again then. It's just another compartment in the vaccination sequence. So hold on, maybe I don't even need to do this. Maybe I can just.
So as an output, you're going to get essentially an Excel spreadsheet that will provide the numbers of, say, cases, hospitalizations, that sort of thing, for each of the different groupings that you set up.
See, this is how we do it. So let me just make this a little bit. There you go. So this is how we would simulate this, right? So we have, say, immunization level 1, which would be unvaccinated, level 2, which would be dose 1. Then, after 14 days, the vaccine actually takes effect, right? Which is the protection development. So this moves you to the level 3, which is protection achieved. Then you have dose 3. Then you have protection achieved. And then you would add to this after 2 months, say, where you have another box where it says now the protection has waned. That's how we did it.
Yeah, and you also are you also able to put the effectiveness of the vaccine for each level. Yeah, so that's, I think it's another window.
Yes, so you can have as many levels as you need.
Yeah,
I think just from coding, just in its current version, I think you can only go up to 9, but 9 should be sufficient, I think.
We have also some questions from Jumi, if you can.
Yes, so was the app in Python, R, or Matlab? Neither. We were trying to get away from these. So it's a native Windows app. You install it and it just runs, and you get that menu that you see there. But as far as the language that we use to develop it, it's modern Fortran. So, you know, the good old Fortran, which is generally used for high performance computing, which we didn't use this. We didn't use any high performance features, but we did use the modern part, which means we have some object orientation in it, so because that was advantageous for us to use. And there was another question: does it allow fixed and or time dependent parameters? It does allow time dependent parameters in a sort of a workaround, in that the parameters, for simplicity, you see them here. Let me bring that up again. I forgot, am I sharing anything at this point? I guess I'm not, but I can share right away. So, okay, so the parameters, like for example here, where was this? Stratifications, public health measures, and so on. So these are all just one number, right, for each, which means that they're constant in time. However, what one can do is, when one tries to run a simulation, then that would, okay, I haven't initialized the population, so it won't let me run it, but it asks you for how many days you want to run it. So then you can run it for, let's say, 10 days, then change the parameters and run it for another 10 days. And you can save the results at each time step like that. So that's how you can do time-dependent parameters, by running it for certain periods of time and changing the parameters when you go from one time interval to the next one.
There is also a question from Gabrielle, right?
Hi. Just really quickly, recognizing that our time is almost up. Marianne, you mentioned that you ran Ashley's model initially way back. I guess it was like March or April. No, it was March 2020. I ran it too for our population. So you ran it for your population in Durham, and said that it was an overestimate, and it was terrifying for me too to see the numbers that came out of our when I ran the model. But and have you found that your model, this one you developed, has been much more accurate to your case numbers? And I mean, I guess what I'm getting at is it, and I guess it is, but beneficial to have a more local solution than a provincial or a national solution for things like this?
Yes, definitely. It's much more realistic. I think, yes, I remember those days, and Anjali probably remembers those days when they're, you know, 30,000 deaths or something in Durham. Like, I don't think that's going to happen. No, it wasn't that high. It was maybe 5,000 in the next 2 months. It was a lot. And it's just like that. I can't see that. We found these numbers actually quite realistic. And when we have gone back as well, so initially when Fangli was doing some of the earlier projections, she would then have a slide in there of how they compared to what she projected, and they were quite close.
Yeah, so we compared the projected case numbers, and also the reported case number, as well as the hospitalization. They're very close. We didn't put in the slides, but yeah.
One quick question: does the model can predict multiple waves or just the one wave that will occur?
It can predict as many waves as it needs to. It depends on the duration that you simulate. And of course, to get the wave effect, right, you would need to update the parameters every now and then, which sort of connects back to what we were discussing, that if you want to have time-dependent parameters, you have to, simulate a certain time interval over which the parameters are more or less constant, and then change them and simulate the next. That's another feature, right? You can load initial conditions from the previous steps to start your next. I shouldn't say step, because step has a connotation in numerical simulation. I should say interval, simulation interval. So you can use that and use it as a starting point, and then do it for the next interval and so on. So as these parameters change, then yeah, you can see the waves and all that.
I think it's time. And thank you very much for the nice presentation. I think